Let us look at how we're actually now going to capture all these WBA assessments. So this is when we're talking about the ePortfolio and the tools to actually capture all these little interactions. And a key part of the WBA conversation and what you are actually capturing is what we're going to call an entrustment decision. So entrustment decisions is a completely different way of thinking about assessment methodologies. We are all traditionally used to having an assessment that looks backwards. So we are looking at, is this patient competent in the assessment that they've just done? Is that a pass-fail? Or in the procedure that I've just observed, do I think they did that procedure well enough or not well enough? And you might have a checklist that makes a decision on whether somebody, how they've performed in that particular procedure. Entrustment is an exciting way of looking at the way we actually extrapolate our trust in somebody by what we observe. So sometimes you will observe somebody doing a particular procedure and say you've got somebody's a registrar is particularly good in surgical procedures, and you watch them do some extraordinary cesarean sections, for example, you can potentially extrapolate that they will also have a similar skill in doing other similar procedures without having to observe every single procedure. So you might end up having a trust. For example, if you notice a registrar is very good in taking a good history and doing a good examination, you're not going to observe that registrar with every single examination of every single system, because you're already extrapolating, this is a skill that this registrar has, and I can trust that they are able to take a history or able to do an examination in the future without me having to be present. So the entrustment levels are very simple. These are the ones that's proposed by Ten Cart and that we'll use in South Africa. So in level 1 is basically you're observing only standing in the room. Number 2 is direct supervision. So for example, in a theater scenario that you're actually assisting the registrar while they're busy doing the procedure, or you're in the room while they're busy doing the consultation. Level 3, which is where most of our registrars actually operate, is indirect supervision. That means we're happy for them to be in clinic and we're happy for them to be on call and actually see patients, but we do not, they still need to be able to contact us if there's any concerns, and we still expect them to give us feedback on the kinds of experiences that they've been having in the clinics. So we're keeping an eye on them, but we don't have to be in the room. Where we often want to get to is level 4, where we're now happy that they can independently perform. And with remote supervision, we actually mean here a little bit like most doctors operate. So even if you're a qualified specialist, or you will still have a scenario where you're seeing a patient and think, well, actually this, I'm not sure how to manage, and I'm still going to contact a colleague for advice. So you're not, you're not the top expert in your field, but you are able to run a practice independently. So in family physician, for our 22 EPAs, we want all of our registrars to be able to get to this level 4 in all of the EPAs before they go and write their final Part 2 exam. A level 5 is when you actually have somebody that is so good in a particular EPA or area that they should actually be able to supervise and train other people. And you might have some of your registrars that achieve that EPA level 5 in particular areas during their rotation. So when we look at these elements of trust, it's forward-looking. You are trying to see, what can I trust them to do in the future? And it's based pretty much on patient safety. So a good way of thinking of it is that now my registrar is completed, they're now a pediatrician. Will I take my child to this person? So that trust is also, do I trust that they can look after a person safely? It's all based on observed competency. So over the years, you've either observed them themselves in action, or when they've presented cases, or had feedback from other colleagues, but it's not just based on how they've performed in an exam. And what's really lovely with entrustment is it includes professional behavior. So you might have somebody who's clinically very good at managing all the clinical cases, but you're concerned about some of the communication skills that they're having with patients. And so they might not lead to really level 4 until we've helped them to actually address those issues as well. What's also great with trust is you can also then say, be specific in trust, as I trust you to be able to do a cesarean section, but I don't just trust you to do a cesarean section where there might be massive complications. So the trust also can include the limitations of what you think they may or may not be able to do independently. This is just a fun entrustment proposal from the anaesthetists. that gives an idea of how we also have an instinctive level of trust that can actually then be translated into a scale from I'm not comfortable leaving the operate room, brief coffee break, maybe I'll take a lunch break. I can not be in theatre at all, but I'll just check in every now and then. I can wait until they call me. And you can see these kinds of levels is what we're all doing we have to be able to decide how much do I need to be present when my registrar is doing the job. And we can interpret that now into actual entrustment levels. I'm going to give you just an example of what a work-based placed observation tool might look like to now gather any of these. So there are a variety of different projects in place at the moment to start looking at how we're going to capture WBA. And there's sort of two extremes. On the one extreme, or two polarities might be a better word. On the one polarity is the family physicians who love forms and paperwork. So we have created 14 different work-based place observations for different kinds of scenarios that can be filled in. Your surgical disciplines like ops and gynae and surgery would like to be more efficient, and it's looking at a single tool. At the moment, we are not trying to be too prescriptive on what tools each college will use. The colleges will decide what's going to be best. And I think over years, we will end up working more and more towards some sort of standardization. With the big summative tool at the end will have to be standardized and have to be the same across all the disciplines. But at the moment, within each college, there will still be some variety on what kind of tools people will use. I'm going to show you a pilot tool, I would call it, or still this is not an actual implemented tool, but it's based on some of the tools that are out there. And just to give you an idea what we expect to go into that tool. So the way the tool will work is it'll be two parts, and the person who will take responsibility for the tool will be the registrar. So the registrar, after they've had a WBA, say they've just been assisted by their consultant to do a cesarean section, and now they would like to actually have some, maybe even afterwards, they had a quick feedback discussion, and the consultant gave them some input on that cesarean section. The registrar now has to go and create this little form. This will hopefully all be on apps. We don't want to go anywhere near paper. And you can see the registrar will fill in the details of the name of the registrar. There'll probably be a little block, drop-down menu, the department where it happened, the supervisor, etc. And then you can see here there's lots of different types of observations, sort of in 4 different groups, whether it's direct observation, and then you give feedback afterwards, or when you're busy having a discussion around a particular scenario, whether it's a longitudinal review, like at the end of a rotation, or where you're actually doing a product evaluation. And the registrar will tick which one it is. This is why family medicine has lots of different forms, and then you can just describe what that actual activity was. It also includes a self-assessment or reflection for the registrar themselves to fill in on their form. So once they fill that in, they send a link to the supervisor. And the supervisor actually only has to fill in a very briefly, firstly, a supervision level. So those 5 levels we mentioned earlier. And what's important is one of the decisions with the forms, or one of the recommendations with the forms, because we don't have final decisions yet, is that you notice we haven't put numbers in here, mainly because people get very fixed on numbers, and registrars feel terrible if they get a 2. But the idea is we're not looking at competency. If you've never done a procedure before and I still need to assist you every time you do it, then a 2 might be extremely reasonable in terms of your ability to do that unsupervised. So it takes a little bit, trying to take a little bit away the pressure of this, the assessment aspect of this. But the important bit is the feedback. So being able to, and we'll talk about in the feedback session in detail, first looking at what was done really well, some suggestion of something that could be done differently, and all very descriptive, and then an action plan to actually help them get more and more towards entrustment. So again, these tools will slowly be developed over time, but literally it takes 5 to 7 minutes, if as much, to fill in one of those tools. And the idea is to do it as quickly as possible after the assessment have taken place. So we mentioned earlier that each EPA is now going to give milestones of what level of entrustment we expect them to be achieving over the 4 or 5 years. So in family medicine, where our registrars do an ops and gynae rotation, and they do that during their first year, we might say we want them to be at level 3 or maybe even level 4 for this particular EPA at the end of their first or second year. During the time when they're working in that EPA, so they're in Ops and Gynae, for example, we're expecting that levels of complexity to increase over time. So it's quite acceptable to be a level 2 or 3 when you first start out. And the idea is that this is not a pass or a fail, or that we're going to aggregate the amount of numbers, that you've had, and now that tells us whether you are passing or failing the EPA. If you scored a 3, 3, 3, 3, 3 with cesarean section over the year, and then towards the end of the year, you suddenly have 2 observations where you are a 4, then great, you have reached your goal, you have reached your journey. We can now trust you to do a cesarean section, and we will disregard the 3s that you've had for the rest of the year. And then eventually there's a certification of trust as a capstone event for that particular EPA. So we will eventually sign off that whole EPA, say managing pregnant women, and saying you are now entrustable to do this particular EPA. And that will be more of a summative assessment and also an entrustment decision. So obviously, to capture all these little different entrustment decisions, we need a portfolio. And there's, again, a technical stream that's trying to figure out what will be the best way to do this. Every observation, every teaching, all of our activities are going to go into that ePortfolio. And the clever bit is that every single time you link an activity, whether it's a teaching or a WBA or whatever it is, that you're going to link it to a specific EPA. So that will give us the possibility to judge for that EPA, what are all the things that you have done there. So some activities you might simply record. So say you've done an ESMO-E, for example, for Ops and Gynae, then there will be, and you're going to just submit the fact that you've done an ESMO-E, and you might even have a self-reflection on that, on what you have learned. And then you'll have particular activities that's now got these entrustment decisions. So you've done your ESMO-E, and that you've logged under that EPA number 2, but you also have various other activities that's happened during the same time. So when we then look at the dashboard for a specific registrar, and that dashboard is owned by the registrar, with supervisors being able to look at that dashboard and give input. But then you can see for a particular WBA, these were all the entrustment decisions, this was all the feedback, this is all the courses they did, this is all the reading, this is their self-reflection, this is the time they spent in a particular department, and that's going to help us make a decision about those EPAs. Those decision happens in clinical competency committees, and we'll talk about that in the next tutorial.